Everything you were told about preventive medicine may be protecting you less than you think. Not because medicine is wrong, not because your doctor is careless, but because the system that designed most routine screening protocols built them for someone who is 50 years old. And if you are 65, 70, 75, or beyond, you are simply not that person anymore. The risk-to-benefit equation is different for you, substantially different, and almost nobody in a 15-minute appointment has the time to sit with you and do that math out loud. My name is Dr. Elizabeth Monroe. I trained in internal medicine during my residency years at Massachusetts General Hospital in Boston, and I completed a fellowship in geriatric medicine at Johns Hopkins in Baltimore. For more than 2 decades, I have worked with adults in the 2nd and 3rd chapters of their lives. I have seen what happens when screening medicine runs on autopilot, when tests that were designed for younger bodies get ordered year after year simply because they are on the checklist, because the visit ends in 5 minutes, because nobody stopped to ask whether this particular test still makes sense for this particular person. What I am going to share with you today is not an argument against medicine. It is an argument for being an informed participant in your own healthcare. We are going to walk through 5 specific exams, tests you have likely had, tests your doctor may recommend at your next appointment, and I am going to show you exactly what the scientific evidence says about the risk-to-benefit balance at your age. Stay with me through all 5. Number 3 is the one that genuinely stops people in their tracks when they hear it for the first time. And number 5 affects millions of older adults quietly right now, without them ever being told. Before we begin, I want to hear from you. Drop your city or your country in the comments below. I read every single one. It helps me understand who is part of this community and what to cover next. Let me give you the one framework that ties everything together. I call it the screening shift, the moment in your health journey when the math on routine testing quietly changes direction. Most people are never told this moment has happened to them. Here is how preventive screening works in your 40s and 50s. The logic is clean and it is correct. You have potentially 30 to 40 years of life ahead. You detect a problem early. You treat it. You recover. You gain decades of healthy life that you might otherwise have lost. The investment of the test and everything it might set in motion makes complete sense. After 70, 3 things shift that calculation. First, many conditions detected by routine screening in older adults are what researchers call clinically insignificant. They exist. They appear on scans and lab values, but they grow slowly. They cause no symptoms, and statistically, you are very likely to outlive them without ever knowing they were there. Think of them the way you would think of a hairline crack in the foundation of a house you plan to live in for 2 more years. Is it real? Yes. Does it require an immediate, invasive, costly repair? Almost certainly not. But medicine has very few tools for saying, found something, leaving it alone, and moving on. The moment a result lands on a chart, a clinical cascade tends to begin. Second, your body's tolerance for intervention has changed. The biopsy or surgery or procedural workup that a 58-year-old moves through with a 2-week recovery can, in a 78-year-old mean weeks of hospitalization, a permanent change in function, or a complication that becomes its own chronic problem. Every intervention now carries more weight. Third, the tests themselves produce different false positive rates in older populations. The reference ranges most labs use were built from studies of younger adults. When your result looks abnormal through that lens, you get pulled into a follow-up not because something is wrong, but because your biology was measured against the wrong ruler. That is the screening shift. It is not that the test is wrong. It is that the math changes after 70. Before we move into the 5 exams, I need to say something important. If you are currently experiencing sudden one-sided weakness in your face, arm, or leg, sudden difficulty speaking or understanding speech, a curtain of darkness passing over one eye, or a new and severe headache unlike any you have had before, please stop watching and call emergency services immediately. Those are potential signs of a stroke or TIA, and nothing in this video applies to your situation. This video is for people who feel well and are evaluating routine screening decisions. If you have active symptoms, please get seen today. Now let's begin. The first exam on this list is the PSA test, the prostate-specific antigen blood draw that many men receive as a routine part of their annual physical. I want to be precise here because this topic requires it. The PSA test has saved real lives. For men in their 50s with significant risk factors, family history of prostate cancer, African American heritage, specific genetic markers, it is a legitimate and valuable tool. I am not arguing against it universally. What I am saying is this. For men over the age of 70 who have no symptoms and no significant risk history, the United States Preventive Services Task Force issues a D recommendation against routine PSA screening. A D recommendation means there is moderate to high certainty that the harms outweigh the benefits. That is as direct as guideline language gets. The reason centers on a problem called overdiagnosis. The false positive rate of the PSA test in men over 70 approaches 50%. Nearly half the time, an elevated reading in that age group reflects something other than cancer. Prostate inflammation, benign enlargement, a recent infection. But that elevated number still triggers the standard next step, a biopsy. Multiple needles passed into the prostate gland with documented risks of infection, bleeding, and urinary complications. And then, even when a biopsy confirms cancer, we face the harder truth. Most prostate cancers found in men over 70 are low-grade and biologically slow. Studies published in the New England Journal of Medicine have documented this clearly. A substantial portion of screen-detected prostate cancers in older men are the kind a man would live alongside for the remainder of his life, not die from. But once that word appears in a chart, the clinical machinery moves forward regardless. Think of it like a very slow leak in a faucet at the back of the house. The water is dripping. If you had 30 years and no complications ahead, you might schedule the repair. But if the plumber has a 40% chance of damaging the main wall getting to it, and the leak will never reach the living room in the time you are there, the repair may cause far more disruption than the leak ever would have. Harold was 73 years old when I sat with him in my office for the first time. He was a retired farmer from the Texas Hill Country, still running the land his father had left him, sturdy and clear-eyed. A prior doctor had been ordering annual PSA panels. 1 year, the number came back elevated. A biopsy confirmed low-grade prostate cancer. He was referred to a radiation oncologist who recommended a full treatment course. Harold slowed down. He asked questions. He read whatever he could find. He eventually chose active surveillance, careful monitoring with no treatment. 3 years later, he was still farming. His PSA had barely moved. His quality of life was untouched. He had not lost his energy, his continence, or his independence. He had simply chosen to understand the math before allowing someone to intervene in something that may never have harmed him. The question to bring to your doctor is not whether to screen. It is this: if we find something, what would we realistically do about it given my age and my health? That conversation changes everything. This brings us to the second exam, one that many of you have probably navigated already. Colonoscopy is one of the genuine achievements of modern medicine. Between the ages of 50 and 74, it has real, documented, meaningful benefit. It detects colorectal cancer early. It removes precancerous polyps before they become dangerous. If you are in that window, please do not let this video talk you out of it. But after 75, the evidence shifts. The U.S. Preventive Services Task Force recommends that the decision to continue screening colonoscopy be individualized, carefully evaluated against your specific health status, your prior screening history, and your risk factors. After 85, the guidance is unambiguous. Routine screening is not supported by the evidence. The reason is not that colon cancer becomes less real with age. It is that the procedure becomes riskier. At the same time, the potential benefit shrinks. A 2024 analysis in PubMed evaluating patients between 76 and 85 found that in the broadest comparison group, the risk of death or serious hospitalization within 30 days of a screening colonoscopy approached 2.3% in the oldest patients in that cohort. A meta-analysis published in the gastrointestinal endoscopy literature found that adults over 80 face a 2.5 times higher risk of intestinal perforation during colonoscopy compared to younger patients. A perforation is a tear in the wall of the colon. In a 60-year-old, it is a manageable surgical complication. In an 82-year-old with other health conditions, it can mean emergency surgery, a permanent colostomy, an extended hospitalization, and a recovery that fundamentally alters what a person is able to do. The procedure that was meant to protect a life can, in that age group, directly threaten its quality. Helen was 78 when she came to my practice. She'd been a postal carrier in coastal Maine for 32 years. Fit, independent, walking 2 miles most mornings. 3 prior colonoscopies in her 50s and 60s had been completely clean. No polyps, no family history, no symptoms. Her new doctor had placed her on the automatic scheduling rotation. When we reviewed her individual picture together, the evidence was clear. 3 clean scopes, no warning signs, no risk history. We discussed a non-invasive alternative, a stool-based FIT test, done at home, 0 procedural risk, and capable of detecting genuine warning signals in the colon. Helen made the switch. 2 years later, she is still walking those 2 miles. If you have symptoms, blood in your stool, a persistent unexplained change in bowel habits, a strong family history, that conversation is entirely different. Symptoms always override screening guidelines. Please see your doctor. What changes after 75 is the automatic symptom-free repetition of a procedure on a calendar schedule, regardless of your individual situation. Type 2 in the comments if you are still with me. The next 2 are the ones most people have genuinely never heard challenged before. Here is where it gets interesting, and I mean that seriously because this third one surprised even some of my colleagues when the updated evidence came through. Carotid artery ultrasound screens the large blood vessels on either side of your neck that carry blood from your heart directly to your brain. The premise is straightforward. Find a blockage, address it, prevent a stroke. Who would argue with that? The United States Preventive Services Task Force argued with it in 2014, reaffirmed that position in 2021, and published their reasoning in JAMA. The American Heart Association and the American Stroke Association agreed. All of them recommend against routine carotid artery screening in adults who have no neurological symptoms. Here is why. The standard treatment for a significant carotid blockage is surgery, a procedure called carotid endarterectomy, in which a surgeon opens the neck and removes plaque from inside the artery. It is serious surgery with a documented stroke risk during and immediately after the procedure. In asymptomatic patients, the USPSTF found with moderate certainty that the harm of screening, including the surgical cascade it triggers, outweighs its benefit. Think of the carotid artery like a river with a partial sandbar forming on one bank. The current is still moving. Nothing catastrophic is happening. When a routine scan finds that sandbar, the instinct is to dredge it out. But the machinery moving through the current can dislodge pieces of that material and send them directly downstream to the brain. The intervention to prevent a stroke can, in asymptomatic patients, cause one. Walter was 74 years old, a retired electrician from Western Pennsylvania, when a mobile health screening van set up in his church parking lot and offered free carotid ultrasounds. He had no symptoms, no mini-strokes, no vision changes, no weakness, no unusual headaches. The scan showed a 60% narrowing on one side. He was referred to a vascular surgeon. Monitoring visits began. Then a conversation about surgical intervention. Walter came to me during that process, genuinely frightened. when we reviewed what the major medical bodies actually recommend for people in his situation. Asymptomatic, no prior neurological events, something visibly changed in his posture. He went back to his primary care physician with targeted questions about symptom-based monitoring rather than procedural planning. Walter is now 77 years old, still has the partial narrowing, still has no symptoms, and is actively managing the actual modifiable risk factors for stroke, blood pressure, blood sugar, physical activity. Let me be clear one more time. If you have had any sudden vision change, any brief episode of weakness on one side of your body, any moment where speech slurred and then cleared, those require urgent evaluation. What this evidence addresses is routine screening in people who have none of those experiences. How many of you have had a carotid scan you never thought to question? Tell me yes or no in the comments. The fourth exam is the annual electrocardiogram, the ECG or EKG. This one has been part of the routine physical for so long that questioning it can feel almost strange. Leads are attached to your chest. A printout is produced. Your doctor glances at it and says everything looks fine. For patients who have cardiac symptoms, palpitations, chest discomfort, shortness of breath, a history of arrhythmia, or diagnosed heart disease, an ECG has genuine clinical value. I order them regularly in the right context. For asymptomatic adults at low cardiovascular risk, the USPSTF has recommended against routine resting ECG screening since 2018. Their finding, harms are at least small and may be moderate, including unnecessary invasive procedures, over-treatment, and what they specifically call labeling. The lasting psychological cost of being told you have a cardiac finding, even when that finding poses no measurable risk to your health. The mechanism here is the cascade effect I described earlier, but with a specific and well-documented path. A resting ECG in an older adult picks up a minor conduction variation, something common and clinically meaningless in a healthy 70-year-old. The variation appears on the report. The report triggers a referral. The referral leads to a stress test. The stress test returns an equivocal result. The equivocal result leads to a catheterization, in which a thin tube is threaded through your blood vessels into your heart. A catheterization is a real procedure with real risks: bleeding, vessel damage, arrhythmia, and in rare cases, it can precipitate the very cardiac event it was meant to prevent. All of it set in motion by a finding that, in an asymptomatic person, would likely have never affected their health or their life. Ruth was 69 years old, a retired bookkeeper from a small community in rural Tennessee, when a routine ECG at her first appointment with a new doctor showed a minor conduction variation. Her doctor said it was probably nothing but worth checking out. Over the 4 months that followed, Ruth went through a stress test, a cardiac MRI, and 2 specialist consultations. Every result came back reassuring, but the anxiety of those 4 months was not reassuring. She told me later that she had become afraid of her own heartbeat, that every time she climbed stairs or walked quickly, she was listening, waiting, braced. The test had not improved her life. It had, for a substantial period, diminished it. Write your age in the comments. It shapes which topics I cover next, and I genuinely want to know who is watching. Now for the 5th exam. This one tends to land quietly because it involves something that sounds so routine and low stakes, a blood draw and a single number. But for a significant portion of older adults, especially older women, it may be generating diagnoses that do not reflect disease at all. The thyroid screening I'm talking about is a TSH test, measuring thyroid-stimulating hormone as part of routine lab work. Here's the problem. TSH naturally rises with age. This is a documented normal physiological change, but most laboratories in this country apply a single reference range to all adult ages, a range that was established from studies of younger populations. The upper limit most labs use is 4.5 MIUL. For a 45-year-old, that is appropriate. For a 75-year-old, it may not be. An analysis of the National Health and Nutrition Examination Survey published in the Journal of the American Geriatric Society found that the 97.5th percentile for TSH in adults between 70 and 79 years old was 5.9 mmIUL. In adults over 80, it was 7.5 mmIUL, meaning a healthy 77-year-old with a TSH of 5.5 may be completely within the expected physiological range for her age, but her lab report will flag her as potentially hypothyroid. The Cleveland Clinic Journal of Medicine has documented that the over-treatment rate for subclinical hypothyroidism in elderly patients exceeds 20%. What does over-treatment look like? It looks like a TSH pushed too low by levothyroxine, and a suppressed TSH in an older adult is specifically associated with atrial fibrillation, accelerated bone density loss, and in long-term studies, increased mortality. You take the medication because a number looked high. The medication pushes the number too low, and now the treatment itself becomes the problem. Margaret was 71 years old, a retired librarian from a farming community in Iowa, when her internist ran a routine thyroid panel as part of her annual labs. Her TSH came back at 5.2. She was started on levothyroxine without a detailed conversation about what that number actually means for a woman her age. 2 years later, she came to see me with palpitations and a new finding of early bone density loss. When I reviewed her current TSH, now artificially suppressed, the picture clarified quickly. We had a long conversation about age-adjusted reference ranges, about what her original result might have represented for a woman of 71. She brought those questions back to her prescribing physician. That conversation, which should have happened 2 years earlier, finally happened. I am not telling you to stop your thyroid medication. I am asking you to bring one question to your next appointment. Was the reference range used to diagnose me appropriate for my age? That is a question with a correct answer, and the answer may change everything. Here is what I want you to do this week. Step 1. Write down every routine screening your doctor has ordered in the past 2 years. PSA, colonoscopy, carotid ultrasound, ECG, thyroid labs, any imaging that came without symptoms prompting it. Step 2, next to each one, write a single word, symptoms or routine. If it was routine, move to Step 3. Step 3, before your next appointment, put this question in your phone or on a card and bring it with you. Given my age and my health status, what is the realistic benefit of this test, and what would we do differently if it found something? Any good physician will welcome that question. Step 4. If you are currently taking a medication that originated from a screening result rather than from symptoms, a thyroid medication, a statin, a cardiac medication following an ECG finding, ask your doctor directly whether the threshold that triggered the prescription was validated for your age group. Step 5. Share this video with one person you love who is navigating their own routine screenings. Not to alarm them, to give them language for a conversation they deserve to have. I want to close with something I believe deeply after 20 years of sitting with patients in the years that matter most. The goal of medicine after 70 is not to generate findings. It is to protect your independence, your energy, your quality of life, and the things that genuinely matter to you. There's a difference between a system that searches for problems and a system that serves the life you are actually living. The best physicians I have known understand that recommending watchful waiting sometimes takes more courage than ordering another scan, that doing less can require more wisdom than doing more. The 5 exams we covered today are not villains. They save lives in the right context, at the right age, for the right person. What I am asking you to do is know whether you are that person. Get the math done in the room with you. Ask the questions. You deserve that conversation. If this video gave you something useful today, please hit the like button. It helps practical, evidence-based information like this reach more people who need it. And subscribe, because every week I do exactly what I did today. I go through the actual research, find what the evidence says, and bring it to you without the constraints of a 15-minute appointment. Before I go, one question for you. Which of these 5 exams surprised you the most? Tell me in the comments. I read every single one. Take care of your body. It is the only home you have.